Welcome to GastroGuide MD, your trusted source for in-depth knowledge on gastroenterological diseases. Today, we are exploring the complex world of pyogenic liver abscesses, shedding light on their epidemiology, underlying mechanisms, clinical presentation, diagnostic approach, and effective treatment strategies. Our goal is to provide a comprehensive understanding that empowers healthcare professionals to make informed decisions for better patient outcomes. Pyogenic liver abscesses are relatively uncommon, but serious infections. Their incidence is approximately 2.3 cases per 100,000 people, but this rate can reach up to 17.6 per 100,000 in Asia. Several risk factors increase susceptibility, including diabetes, hepatobiliary diseases, liver transplantation, and the use of proton pump inhibitors. There is also a significant association with colorectal cancer, particularly when the liver abscess is caused by Klebsiella pneumoniae. These abscesses can originate from multiple sources. One common source is the biliary tract, often due to cholangitis or malignant obstruction. Another route is through hematogenous spread, typically involving Streptococcus or Staphylococcus aureus. In such cases, screening for endocarditis is recommended. A third pathway is portal pyemia, which may occur secondary to intra-abdominal infections like diverticulitis or appendicitis. The infections are typically polymicrobial, involving Escherichia coli and anaerobes. In Asia, Klebsiella pneumoniae is the predominant pathogen and is particularly associated with colorectal cancer. Other significant pathogens include Streptococcus aeruginosus, Enterococcus, and Staphylococcus aureus, especially in patients with immunosuppression or hematogenous infection. Patients with pyogenic liver abscesses often present with fever, occurring in 90% of cases, along with right upper quadrant pain in 50 to 75% of cases. Other symptoms include nausea, anorexia, and weight loss. Physical examination may reveal hepatomegaly, jaundice, which is rare, and abdominal pain. Laboratory tests often show leukocytosis, elevated C-reactive protein, and increased alkaline phosphatase and bilirubin levels. Imaging plays a crucial role in diagnosis. Ultrasound may reveal a hypoechoic or hyperechoic lesion with or without septations. A computed tomography scan typically shows a hypoattenuated lesion with possible peripheral enhancement after contrast administration. In cases where the diagnosis remains uncertain, a combination of ultrasound and computed tomography is recommended. Blood cultures are positive in approximately 50% of cases, and image-guided aspiration or drainage should be performed for culture, as anaerobic organisms are often underestimated. If the etiology remains unknown, screening for colorectal cancer is advised. It is also important to exclude amoebic liver abscess by testing for Entamoeba histolytica serology. Treatment begins with empirical intravenous antibiotic therapy. Common regimens include a third-generation cephalosporin combined with metronidazole or piperacillin-tazobactam, with or without metronidazole. Another option is ampicillin combined with gentamicin and metronidazole, with gentamicin typically discontinued after 48 to 72 hours. For abscesses smaller than 5 centimeters, aspiration with or without drainage is recommended. For larger abscesses, catheter drainage is preferred, and surgery is considered if catheter drainage fails. The total duration of treatment is 4 to 6 weeks, starting with 2 to 4 weeks of intravenous therapy, followed by oral therapy if clinical improvement is observed. Follow-up imaging is only recommended if there is an unfavorable clinical evolution. Colorectal cancer screening should be performed, especially if no hepatobiliary cause is identified. The prognosis varies, with a mortality rate ranging from 2 to 12%. A worse prognosis is associated with advanced age, comorbidities, and infections caused by anaerobes or enterococci. Thank you for choosing GastroGuide MD as your trusted source for gastroenterological knowledge. We hope this comprehensive overview enhances your understanding of pyogenic liver abscesses and supports your clinical practice. Stay informed, stay prepared, and continue making a difference in patient care.